Hello, everyone from around the world. I'm Dr. Joel Gelfand from the International Psoriasis Council, board member of, and today we're meeting to discuss monkeypox and psoriasis patients, what a dermatologist needs to know. And a quick welcome and introduction to what we're going to do in this next half hour. So first, about the IPC, it was founded in 2004. It's a dermatologist-led voluntary global nonprofit organization with a network of 129 psoriasis experts, thought leaders, and professionals dedicated to improving patient care around the globe. And we believe that people with psoriasis, no matter where they live in the world, no matter how complex their symptoms, should have access to the best available care to them, and that ultimately a world without psoriasis is possible. And I want to encourage you all to visit our website for resources. We have a number of different educational offerings, fellowship programs, and meetings. So I want to encourage you to take a look at what we have to offer. All right, so today's program is about monkeypox and psoriasis patients, what a dermatologist needs to know. And very pleased to have myself and Dr. Luis Puig, who's an internationally recognized expert in the field of psoriasis, who will be leading our discussion later on. We also have Dr. Alba Catala, who's a specialist in medical surgical dermatology and venereology. She has actively participated in different research protocols on managing psoriasis, the skin manifestations of COVID-19, and infectious contagious diseases of a sexual nature. Dr. Catala is currently the part of the sexual health program at the Hospital Clinic de Barcelona, and we're going to go over to Dr. Catala to lead us off in this discussion. And if you could share a screen.
Okay, dear colleagues, thank you for inviting me. I have no disclosure. Since the beginning of the current outbreak, several series of patients have been published. We participate in the series published by the British Journal of Dermatology and also by in the New England. All the data from all the papers are very similar and are distinctive from the previous outbreaks. In late May, when we started visiting patients of monkeypox, we expected a rash similar to smallpox or chickenpox, and also we expected that patients would have fever prodromes before the rash appeared. But what we saw, it was different. Primary lesions in the inoculation areas are pseudopustules, papules that simulate pustules, in which it is impossible to scrap the roof and obtain pus. Similar to other pox viruses, it seems like a mollusca. Some patients presented with a unique pseudopustular lesion, and other with multiple pseudopustular lesions. These lesions are well circumscribed, deep steep, often develop umbilication, are described as very painful and take weeks to heal completely. And also surrounding edema is very frequent, and also lymphadenopathy, regional lymphadenopathy is often associated. We also have seen perioral or oral lesions in the tongue, in the lips, and also willows in the fingers. Few days after the appearance of the first lesions in the inoculation area, secondary eruption of a small macula, vesicula, pustula, and crust can take place. These other lesions are described as more pruritic, not tan painful, and take days to heal completely. May appear in the face, in the scalp, in the arms, in the legs, in the palms, in the soles, and in the trunk. And frequently, not all the lesions are in the same stage of development. At the time of attending for evaluation, most patients had few lesions. Before the information that we had before about Africa, they say that most of the patients had 100 lesions. What we saw, it was different. We saw that most of the patients have 1 to 20 lesions, and having a single lesion was not exceptional. Most of the patients had the lesions in the anogenital area and the face. And in our study, all the patients had extracutaneous symptoms, being lymphadenopathy, fever, asthenia, myalgia, headache, or throat ache, very frequent, but not all the patients had all the extracutaneous symptoms, and not all the patients had fever. So if you have a patient with these kind of lesions and he has not any extracutaneous symptoms, it can have also monkeypox. The majority of patients began extracutaneous symptoms at the same time of the cutaneous symptoms, and only 36% of the patients had prodromes. Obviously, it's different if the patient arrived to your consult at the beginning of the disease or at the end of the disease. For most individuals, monkeypox is a self-limited disease with the symptoms lasting from 2 to 4 weeks, and with a symptomatic treatment, it's enough. However, some patients can have complications as proctitis, tonsillitis or amygdalitis, penile edema, or severe bacterial infection. Also, we have seen more or less 1,000 patients, and we have seen 1% of our patients had ocular involvement, 9 cases, and they require management with ophthalmology. Maculopapular rash was also a complication. Probably it's because immunologic phenomenon, but it's important to rule out toxicoderma and secondary syphilis. During the actual outbreak, few hospitalizations have been reported. The main reasons were provision of adequate pain management to treat complications or for isolating the patients. In the case areas published, all the cases survived with supportive therapy, but some needed antiviral therapy as tecovirimat. But 8 cases in all the world have been reported, 2 in Spain, in patients with underlying conditions. The current outbreak predominantly affects men with a median age of 38 years and who define as men who have sex with men. The percentage of patients with HIV is very high, but they are well controlled, and among those with HIV negative, the percentage of patients taking PrEP is also high. It's important to know that the virus has not preference for a sexual orientation, and that this data may change with the spread of infection in the community. A high percentage of patients have risk factors for sexually transmitted infections, and in the patients in whom the screening was performed, more than a half were positive for a sexual transmitted infection. So having an STD doesn't exclude a monkeypox infection. The possible exposure of monkeypox is unknown for most of the patients, but more or less 25% of the patients had a regular sexual partner with monkeypox, and the suspected route of transmission was sexual close contact during intercourse in the vast majority of patients. And the median incubation period is 6 to 9 days. Monkeypox DNA have been detected in saliva, rectal swab, nasopharyngeal swab, semen, urine, feces, explaining the possible role of bodily fluids in the disease transmission. And this study was very interesting because viral load was higher in lesion swabs than in pharyngeal specimens. This suggests that the skin-to-skin contact is the dominant transmission route of virus during the actual outbreak, whereas respiratory transmission is probably less relevant. Asymptomatic infection have been reported, but appear to be rare. It is uncertain if the patients were completely free of symptoms or paucisymptomatic, but these findings raise concern because maybe people with disease, with mild disease, could contribute to the ongoing transmission. Until now, previous smallpox vaccination and HIV positivity were not associated with symptoms of severity, but most of the patients were receiving effective antiretroviral therapy and are well-controlled HIV population. You can read the diagnosis guidelines, which is updated recently, definition in the ECDC documents, and also documents to guide to prevent of healthcare-associated transmission. It's important to know that a confirmed case is a laboratory confirmed monkeypox by detection of DNA by PCR, and the PCR testing should be performed on lesion samples. It's important to scrap the lesion intensely to increase the sensitivity. And the sequencing of genomes collected in Spain belong to the West African clade and are most identical to other genomes from other European countries. Patients undergoing diagnosis of PCR must remain isolated until infection is confirmed or discarded, and patients are considered contagious and must be isolated until all skin lesions have healed. Information about transmission is evolving. Skin-to-skin contact seems the dominant transmission route versus fomite or aerosol transmission. And it is unknown whether the viral DNA detected in specimens from asymptomatic patients is replicating competent. But this work from Israel highlights the strongest correlation between monkeypox quantitation cycle values to virus infectivity and defines a threshold that predicts poorly or non-infection specimens. Thank you, and I'm here if you want to ask me any question.
That was really a tremendous presentation, Dr. Catala, and thank you so much for your work in the area. And a lot of important information there. This will be available on the IPC website, which will be really useful as a resource for people. And the photographs were really spectacular for educational purposes. So now we'll transition to Dr. Erica Damash, who's assistant professor at Harvard Medical School and a dermatologist at the Beth Israel Deaconess Medical Center and Fenway Health, a community health center in Boston, which focuses on caring for the lesbian, gay, bisexual, and transgender community. She specializes in dermatologic care of transgender patients and also has an interest in drug safety and pharmacoepidemiology. Dr. Damash, thanks so much for joining us today and sharing your expertise with the IPC community.
All right, thanks for having me. I'm going to be talking to your high-risk patients about monkeypox. So that begs the question, who's at risk? In July 23rd, 2022, the World Health Organization declared monkeypox an outbreak and a public health emergency. And since that time, we know that this is a disease that's primarily affecting men who have sex with men. And as Dr. Catala talked about, it's mostly spreading through skin-to-skin contact, usually sexual contact. We have some evidence that individuals who were vaccinated for smallpox previously may be at reduced risk for monkeypox. So there have been a few observational studies suggesting that vaccination against smallpox is about 80% or 85% effective in preventing monkeypox. However, routine vaccination for smallpox was halted in the US and most of the world in the 1970s. So anyone less than age 50 is likely to be unvaccinated. And routine vaccination stopped because smallpox was declared eradicated formally by the WHO in 1980. And there's some thought that psoriasis patients may be at greater risk for severe disease from monkeypox due to skin disease or the psoriasis itself, but also psoriasis treatments such as biologics, other immunosuppressive medications may actually put certain psoriasis patients at higher risk of severe disease. So the good news is we are much better prepared than we were with COVID. So a lot of the newer vaccinations and medications that were developed for smallpox were actually tested in animal studies against monkeypox. So that's why we see that some of these medications and vaccines are actually duly approved for smallpox and monkeypox. And that's in the US anyway, there's an animal rule regulation where certain drugs can be approved when human efficacy studies are not ethical. So clearly in the case of smallpox, it's eradicated. You want to bring this back into the world to test your drugs. So that's why it was tested against monkeypox. Right now, with the vaccines, both the WHO and CDC are not recommending mass vaccination. They are recommending, currently the strategy in the US anyway, is post-exposure prophylaxis or expanded post-exposure prophylaxis. So individuals who have been exposed are at high risk of exposure. The thought is that if the vaccination is given between 4 and 14 days after exposure, the vaccination may reduce symptoms of disease, but will likely not prevent disease. There's some evidence that you see immunological response within the first 2 weeks of a first dose of vaccine. There's really no evidence that this works, but this is a strategy that's being used right now. And in some countries and some states in the US, they are starting a primary prevention vaccination strategy for groups at high risk of exposure. So who is considered high risk of exposure? So pre-exposure prophylaxis should be considered in individuals who are, it's mostly affecting gay, bisexual men who have sex with men, transgender or non-binary people who in the past 6 months have had a diagnosis of another STD, have more than one sex partner, are a sex worker, or anticipate experiencing one of the above risks. And then anyone with presumed contacts, a known exposure to monkeypox. There are 2 vaccines currently available for preventing monkeypox infection. So there's Jynneos, which is also under the name of Imvamune in Canada, Imvanex in the EU. It's a 3rd generation vaccine, and there's ACAM2000. It's a 2nd generation vaccine currently licensed in the US, Australia, and Singapore for smallpox. Worldwide, there's a very limited supply of Jynneos. It's being basically manufactured by a small firm in Denmark called Bavarian Nordic. So they're supplying the world with vaccines right now. There's ample supply in the US of ACAM2000, which is the 2nd generation vaccine, but it has a lot of contraindications. So the 2nd generation vaccine called Jynneos, it contains a live virus that does not replicate in human cells. So it's very different than some of the other live vaccinations that we have available for other conditions. And it's a modified vaccinia virus and Cara. This is a strain that was developed, a smallpox vaccinia virus that was developed and what they did is they adapted to grow only in avian, so avian cells, and it lost the ability to replicate in mammalian hosts. It's administered as 2 subcutaneous injections, 4 weeks apart. It takes about 2 weeks after the 2nd dose for maximal immune response. It's licensed for smallpox or monkeypox prevention. There's no data right now for this in terms of post-exposure prophylaxis. And importantly, it was studied in people with HIV and eczema. So it's considered safe for use in immunocompromised patients and those with exfoliative skin diseases like psoriasis. ACAM2000 is this live vaccinia virus that is replication competent. It's administered as 1 dose. And essentially what happens is once a patient is inoculated, they get a lesion that is called the take. It's actually live replicating virus in the skin. It takes about 6 weeks to heal. People can auto-inoculate themselves with this lesion or inoculate others potentially. And right now it's only licensed in USA, Singapore, and Australia. Availability, I don't think a lot of other countries are even offering this. There's a high risk of myocarditis and pericarditis. So 1 in 175 adults will get myocarditis or pericarditis. Probably worth the risk for something like smallpox, where the fatality rate is around 30%. But definitely consideration in people that you're considering giving to for monkeypox vaccine. So ACAM2000 should not be given to people with many different conditions, but importantly, those individuals for your psoriasis patients, those who have who are on immunosuppressive medications like biologics or methotrexate, or those with severe skin disease should not be given, like psoriasis or eczema should not be given ACAM2000. And that is because you can have severe complications from uncontrolled viral replication. So you can get progressive vaccinia, and then eczema vaccinatum, which is basically spreading of that take lesion to other areas of the body. And these are contraindications for ACAM2000 and Jynneos. There's a long list of contraindications for ACAM2000, but really the only contraindication for Jynneos is allergy to a vaccine component. So based on CDC guidance in the US, ACAM2000 likely contraindicated for many patients with psoriasis. Jynneos is a much safer alternative, but again, there's like very limited supply right now. The other consideration is that people with who are on immunosuppression may have maybe less likely to mount an effective response after any vaccination, including Jynneos, and there's no real way to measure response to vaccination at this time. So it's possible that psoriasis patients on certain medications may be less protected from this vaccine. Right now they're using, they just about a month ago started using intradermal vaccination as a way to increase the number of available vaccine doses. So they're using 1/5 the dose. And they're also doing a one vaccination strategy where they're just really prioritizing people getting at least one dose of the vaccine. So there's some evidence, this is just released last week, the CDC offered some early data about positive signs from the monkeypox vaccine. They found that unvaccinated patients people had 14 times the risk of monkeypox disease compared to people who were vaccinated. So, and this analysis was done from data from July 31st to September 3rd. So we have intradermal vaccination starting around August 9th. So again, not a lot of evidence, but some evidence that the vaccine is effective. For patients that do get monkeypox, they may be eligible for treatment with TPOXX. So this is approved for use for smallpox disease, but in the US, you can get it under an expanded IND, emergency IND. Generally, this is being reserved for patients that are at risk of severe disease. There's not a lot of data in terms of treating monkeypox with TPOXX. However, there's phase 3 that was started about a month ago. So hopefully more data on that will be coming soon. There's increasing concern for possible resistance. So they are really trying to limit distribution of this drug. And it may be considered a treatment for certain psoriasis patients infected with monkeypox that are at risk of severe disease. So patients on antimetabolites, TNF-alpha inhibitors, or people that have severe active psoriasis covering a lot of body surface area. It may be an indication for treatment with TPOXX. What if your high-risk patients cannot access vaccines? So we know that monkeypox is mostly being spread through skin-to-skin contact, mostly sexual contact. So patients at higher risk of severe disease from monkeypox, especially men who have sex with men, should likely, until they are vaccinated, limit the number of sexual partners, avoid sexual contact with anyone with a new undiagnosed rash, and avoid contact with anyone with a recent diagnosis of monkeypox until all scabs have fallen off and a fresh layer of skin has formed. And just some take-home messages. So psoriasis patients may be at greater risk of severe disease from monkeypox due to the skin disease itself. And also some psoriasis medications like biologics and other immunosuppressive medications may put them at higher risk. More vaccinations are likely on the way. So when available, please talk to your psoriasis patients who are in high risk groups about vaccinations. And psoriasis and medications used to treat psoriasis, including biologics, are not a contraindication to vaccination with the 3rd generation monkeypox vaccines. That's it.
Thank you very much. That's been the most informative presentation, as well as that from Dr. Catala. I have one question regarding vaccination with Jynneos or ACAM2000. Since they're attenuated live vaccines, the same kind of precautions that we apply to yellow fever vaccines, for instance, should be applied to patients under treatment with anti-TNF-alpha agents, or for that matter, any interleukin or biologic agents. So you've just, this is a bit of contradiction with what you have just said. Should we recommend our patients to stop, for instance, adalimumab, wait 3-4 half doses, half lives, and then wait 1 month after the vaccination to restart treatment? What's your take?
I think that Jynneos is really kind of a new class of live vaccination. So I don't think that the strategies we use for other live vaccination in terms of like not giving patients with biologics other live vaccination, I don't think that really applies to Jynneos. I think there's a theoretical concern with other attenuated live vaccinations that I suppose that they could reactivate. But this live virus vaccine does not replicate in human cells. So I don't, that would be the only contraindication that I think of. And I don't think that is a risk. And I think it's been shown to be safe in people with immunosuppressive conditions like HIV.
Yeah.
And so
I just told my patients who are high risk to go ahead and get it. If they're on biologics, just for the answers that you just gave, which is that it doesn't replicate in human cells. There's good data that it's okay in people who immunocompromised, like HIV, for example. And it seems like this is something that's a rapid upscale of cases, and there's not a lot of time to wait if people really need to be vaccinated. And
just one question for Dr. Catala. You told us that early that when monkeypox was, let's say, an endemic disease, that the clinical appearance was a bit different from the current appearance when it's transmitted by usually intercourse or close contact. Is it related to the fact that in Congo or in Africa the transmission is like a zoonosis, or what's your take on that?
Yes, because most of the cases are zoonotic or human transmission. It's because airway transmission. So the respiratory route makes more viremia and makes more generalized lesions.
Okay, so the respiratory route, it might be more important in those cases than in the current situation. Good, thank you. That's very informative.
I had a question for our experts. What's the state of the epidemic now? Are the case counts starting to go down, or are they still, or are they plateauing? How are things in Spain, where you are, Dr. Catala?
In Barcelona, in Spain, and also in Europe, the incidence is going down. In July, we were visiting 40 to 50 cases per day. Now we are visiting 1 or 2 per day. So it has been a huge difference, probably because the people know more about the infection and they take care, probably because of the vaccination, and maybe because some of the people who are at risk already get the infection.
And you told us that the presence of viral in the absence of lesions is not known if it can transmit the disease. So
yes. We don't know exactly for how long the people get contagious. We are studying that.
Could you tell us a little bit about how you protect yourself when you're in clinic with a suspected case? What precautions should our colleagues be taking when they're caring for patients?
When we visit a patient that we suspect that has monkeypox, we take the same precautions than with COVID. Glasses, FFP2 mask, and 2 gloves.
So, but it's interesting to me because it's not really a respiratory virus. Yes. So I guess people shouldn't be too anxious if they didn't have a mask on for a minute when they saw a patient.
That's true. At first, we were more worried, obviously, but yes, it's really not so frequent to get infected during the by a respiratory route as COVID. It's completely different. But we have some one case with a girl that was working together with a person who has infected, and they didn't have any other contact, only respiratory route. So it is possible, but it's not COVID.
Okay. All right, very helpful information today. This has been a really educational experience. And for those who are attending, please share your feedback in the chat. There's a link to a SurveyMonkey, so please do that for us. And then, of course, this will be living on the IPC website, so many more people can learn from your expertise. Dr. Catala and Dr. Damaj, thank you very much. And Dr. Puig, thanks so much for joining us today.
Thank you.
Bye, everyone.
Thank you.
Bye-bye. Thank you.